Morning. Morning, everyone. It's great to see so many of you here bright and early here at the joint Festival of Economics and Economics Observatory event. I'm delighted to say that we're starting our new conference. It's a brand new approach where we're trying to bring together economists, journalists, and people at the cutting edge of whatever the topic, whatever the problem is. We're starting, I think, with perhaps the most important topic, the thing that's defined all of our lives for the past 2 years, which is the interplay between health and economics. Just a little bit of housekeeping from me. There are no set fire alarms. Okay, so if the fire alarms go off, we hope they don't. It's because it's a real fire alarm, and you should exit by the fire alarm, the exits which are here, over there, and over there. You can see the green markings. Afterwards, there's space for time for coffee. We hope you'll discuss with all our panelists. And there's also ample space to hang around outside. And given the COVID situation, we would appreciate it if you do that. So you can go out here, and through the back there. Okay, I really hope you enjoy this session. I've been looking forward to it for the past month or so. And I'd like to start by welcoming Chris Giles, who's the economics editor of the FT, and his panel.
Thank you very much, Richard. Just come on and sit anywhere. We don't need to have order here. As Richard just said, my name's Chris Giles. I'm the economics editor at the Financial Times, and it's a great pleasure to be here. Just a couple of other things. If you want to tweet about this, the hashtags are #TalkingEconomics or #EconomicsFest, all one word. I think, just as Richard said, I think the issue of, the exact title is a 1-2 punch, health and economics, but the issue of health and economics, certainly in my life and in my reporting, we would occasionally write about health and economics, and mostly about how much the health service was costing or what sort of organisational changes there might be in health systems. But we would almost never, and I'm trying to think, I think probably never wrote about the interplay between the general economy and health, and that has changed hugely. But I'm just going to introduce the panel. So on my immediate left, we've got Ben Moll, who's a professor at London School of Economics. Then to his left, we've got Mel Cockroft, and she is a senior doctor in intensive care here in Bristol. And then to her left, we've got Paula Lorgelly, who's a health economist and professor at UCL in London. And on the far right of the panel, as you see it, we have Flavio Toxvaerd, who's a professor at Cambridge. So we've got a really expert panel for you here. So before we start, if we think about how health and economics worked in the sort of BC era, before COVID, we would have lots of people like Paula, like health economists who would look at health systems. We would also ask, what should we pay for? How can we afford it? We would ask questions like how best to tax bad things like alcohol or tobacco. And we'd do a little bit of public health messaging, that if there are externalities, if there are communicable diseases, then we would say that there are externalities, that they're spillovers from one person to the rest. But we really wouldn't do much more than that. And just to give a little potted history of how it's changed, I remember in the budget of 2020, I think that was on March the 11th last year, we had a big debate about sick pay, like should you be paying people to stay away from each other just as the crisis was beginning to start. We had the Prime Minister and the Chancellor at the time saying that there was a big trade-off between health and economics, and we'd have to think that to have a good economy meant that people had to keep going to work, and we wouldn't want to be like these other silly economies like Italy, which were having lockdowns because that would destroy our economy. But we soon realised in the summer of 2020, in the spring and summer, that actually countries that had lower rates of coronavirus were generally performing better. Then when we got to the second wave, we learned some really interesting things about adaptation, that people and companies were beginning to adapt very, very successfully to the crisis. So come the second lockdown, the economic effects were far, far smaller. So we lost 25% of our economy in the first lockdown, and I think, this is off the top of my head, about 4% in the second lockdown in January this year. So very, very different, and that is all about how people adapt. Very interesting issues there. Then the amazing emergence of vaccines. And now, just to bring it to the current date, we've had a huge debate about how you should give support to economies going through difficult pandemics, the furlough scheme, and different ways of providing support, and where we're now at the point where we're now saying, well, did we actually give too much support, and are we now creating an inflationary situation in the countries? A huge debate in the US there, and even today here with a 4.2% inflation figure came out at 7 o'clock this morning. It is increasingly one here. Janet Yellen, the US Treasury Secretary, said this week that she didn't think that inflation could be solved until coronavirus was solved. And that shows just, I think, how much the two subjects are now interlinked. So what we've got here, we've got a doctor to tell us how it really is. We've got a health economist to give us the, put us right on all matters of health economist, and we've got Ben, who can talk about trade-offs and macro, and Flavio talk about behaviour, disease. He was working in the economics of epidemiology, or epi-macro, 10 years ago, when it wasn't a sexy subject. So I'm going to ask each one of them, first of all, just to give us one observation about the crisis and one idea. They'll speak for about 5 minutes, and I'll try and keep them to that, and we'll go with Mel first to give us the situation on the ground. I should say, Mel has come off a night shift, so she was in ICU for most of the night. So if she looks a bit tired, she doesn't look a bit tired, but if she does, we know why. Mel.
Thanks. So I guess the most obvious observation is that it is the biggest new thing to face healthcare, I guess, ever in modern healthcare. And we all started off knowing absolutely nothing about anything to do with coronavirus, and had to very much work on our best guesses on previous pandemics and a little bit of knowledge about other coronaviruses, but that didn't really help. But then, since the beginning of it, I think my next observation would be how phenomenal the scientific community has come together to create vaccinations, pretty good treatments now, and that's just phenomenal. It shows how worlds can work together and get things done. And finally, I'd say that sadly it's revealed that we were a system under a huge amount of stress beforehand, which we were just about coping with, and it's, I'd say, broken it now. Both on a personal level and on a resource level. So that's probably a bit of a common thing to end on.
Can I ask, on that last point about resilience, and is that because the NHS was always running, because we sort of run it as a sort of like a military operation? Is it is it always run right on the edge? So when you just have something that pushes it over the edge, that goes wrong? I was
talking to my colleague last night, and I think that sadly it's over-complimenting us to say it's run on a military level. Like there is, we are a bunch of clinicians that have no idea about economics management. We do very little training and all of that, and so therefore our resource use is on a patient-by-patient basis, on a clinician-by-clinician basis. There's very little overseeing of. This is the first time really coronavirus has made us work as like big teams just to try and get one big thing done. So automatically that's a really inefficient, non-lean system, I guess, that we work in. But it was, yes, it had no resilience to leading up to the COVID crisis because of understaffing, whether it's underfunding or not, or bad use of funding, a bit of both, I guess. And so I came back into the NHS in 2013, having been out for 5 years in New Zealand, so in a different healthcare system. And year on year since then, it has got worse. And winter pressures are not winter pressures. They are pressures that you see in July, August, September as well. So we were never in a position to be able to cope with what's happened. But I think even the healthcare systems around the world that run differently, they have also been broken by this. So I think it's about, I think our recovery is going to be harder because of the position we started off in.
Just so we know what the situation is right now in Bristol, what is the ICU intensive care situation for COVID in Bristol?
So we've been at maximum capacity. So ICUs generally, maximum capacity is 80% bed occupancy, roughly. The Southwest has got the least number of intensive care beds per population for most of the, compared to a lot of the UK, and the UK is worse compared to the rest of Europe and other developed countries. So we have been running over 80% capacity. We've been running at 100% capacity and actually what we call surging. So all ICU patients who are on ventilators and other machines should have one nurse per patient. We've been sometimes doubling that to 2 nurses. In the height of the surge, height of the wave, we were having non-ICU trained nurses coming to work with patients. And that stopped because the rest of the services have to carry on. So there are, especially overnight, we are having times where we have to surge patients and double up at the moment. So that's been going on right since the beginning. Our actual COVID numbers are much less than they were in the peaks, but the patients stay on ICU for an average of 4 to 7 weeks. And if there are between 3 and 8 beds occupied out of a 48-bed unit with COVID patients, that's we're maybe cancelling 3 to 5 cancer operations, heart operations, kind of immediately needed operations a day because we have patients that are there for 7 weeks. So even though the actual numbers are quite small as a percentage of our ICU population, they take up a lot of resources that other patients.
Lovely, thank you, Mel. So that's the situation on the ground now. Paula, if I come to you next, why don't you give me your observation and idea?
I just wanted to challenge you, Chris, if it's okay. I think you said when we talked about health economics, and we wouldn't do much more than that. So actually, as health economists, we're not doing anything different. We've just got a new disease to do it with. And so we've been working in pandemics for years. We have health economics colleagues that work in global health, and they've worked in many low and middle income countries. They've worked more recently in SARS. And so we actually have been working in this space. But I think the difference for us as health economists and why, so I was thinking about, what might be the challenge be, and you haven't seen us on the news. So I've seen more of my UCL colleagues on the news, like every night somebody from UCL is on the news, but you won't see a health economist. And I don't know why we haven't been asked or why we haven't put ourselves forward, but I don't know if it's because we can't work in a crisis or maybe as the dismal science we're a bit nervous about, the uncertainty surrounding our predictions. So just a little bit of a challenge there.
No, absolutely. That's very fair.
And hopefully what I hope it will do, and I'm looking at a lot of young faces, is that it will encourage you to get into health economics. So as a discipline, we've been going 50 years in the UK next year with our study group. So, there's a long history of it in the UK. So it is a really good area to work in, even when there's not a pandemic. It's not the best place to work in a pandemic, but it's a great kind of topic. I guess one of my reflections, so I do a lot of work in health technology assessment. A lot of my previous work has been looking at the way that NICE and other HTA organisations make decisions. One thing that's quite glaring for me is things like the vaccine and things like the new treatments that have come through. I haven't seen any cost-effectiveness evidence on them. And I don't know what we're paying for them, and I'm not sure anybody does. I'm assuming somebody does. I'm hoping the JCVI does. But I don't know if they've ever negotiated the price at all. And so it almost seems like in this pandemic, not only have we closed our economy, thrown a whole bunch of money at furlough, we're also throwing a lot of money on interventions and not knowing if we're getting value for money. And I think that worries me for a whole bunch of reasons, not least because we're in a pandemic. So I think given that the UK has put itself forward as a really strong HTA agency. Lots of companies come to the UK first to get listing for many of their drugs because we're seen as a rigorous system. That seems to have kind of gone out the window. So I do wonder what it means for kind of NICE after the pandemic and what place they will have in that sense.
Do you want to just say what NICE is?
So the National Institute for Care and Health and Care Excellence.
And they essentially say whether treatments are worth doing or whether they're value for money or not.
Yeah. So I do know, so I'm from New Zealand, and I do know that in New Zealand they did negotiate the price on the vaccine, and they chose not to go with the first offer that was offered. They waited a little bit, and they're having a slight crisis now. They've had 200 cases today, which in a New Zealand context is a crisis. And they did wait, but they didn't pay over the odds. And so there is a part of me that worries that we've paid over the odds for these vaccines. We now seem to have a stockpile of them somewhere because I think, I'm not going to insult you, but I think actually, nor you, everybody else on this stage is going to get a booster. And I worry that because we've bought them, we're going to use them. But then I think they might be of better use somewhere else in the world.
Well, it's better than the 600,000 doses that they threw out.
Yeah, that really is a scandal. I mean, that to have something. I mean, because I just wanted to challenge you on value for money, because presumably if we have a lockdown or we have a real economic crisis, which was costing us at one stage 25% of the economy, so that is in UK terms very roughly 500 billion pounds per year, not one-off, per year. It doesn't really matter how much it costs because the return is so high. You couldn't think of a return on any investment that could be higher than that.
I think that's very true, but that's not how we normally evaluate health technologies.
No.
We take it from within the healthcare space. So I work a lot on cancer. Cancer hits a lot of people in their most productive years, and they may stop working, and they may need caring. But we don't bring that into the equations when we work out whether it delivers value for money. So the fact, I find it fascinating, and it will be really interesting to look back on what was in that kind of perspective that they took when they do look at value for money, and will it change going forward? So now, for new technologies that are coming forward, particularly when we're looking at, saving the lives of young children with rare disease, will we look at their contribution to society and not just the cost that will be incurred in the healthcare system? So it might fundamentally kind of spin the way that we do health economics in the UK.
Because there's this thing called QALYs, isn't there? How you normally evaluate the effectiveness of treatment, which is a quality adjusted life year. Mm-hmm. Do you want to just explain what that is to people and how it works?
So when we talk about whether something delivers value, it doesn't just deliver value in terms of whether it saves lives, because there's lots of interventions that also improve your life. They don't necessarily save your life. So a hip replacement is not going to necessarily save your life. It's going to mean that you can walk around and get up and down stairs and go about your daily living. And we just have a means of attaching a weight to those life years. So one life year, if you're in full health, is one. But if you're in half health or your quality of life is diminished, then it's less than one. And that's how we work out, these things called QALYs, and we assess things against QALY gains. And I'm not completely up on the literature, but I've not necessarily seen. I've seen some QALY estimates from QALY losses due to the pandemic. And it kind of aligns with this notion that, particularly in the first wave, there's a lot of older people. So, they weren't going to be gaining a lot of years anyway, and they potentially weren't going to be, if we saved their lives, they weren't going to be gaining a lot in quality adjusted life years. But now that, I guess, what you're seeing, Mel, in the ICU is younger people, it's not just their lives that we're saving, but actually we're saving morbidity, and particularly with long COVID, which is a space that I do work in. And so the effect that long COVID could have, which we don't know, because we don't know how long COVID is going to be for, what sort of detriment that will have on your quality adjusted life years.
Lovely, thanks. Ben, do you want to come in and just give an initial reflection and an idea?
Yeah, absolutely. I should preface by saying that in contrast to my three fellow panelists here, I'm a total newcomer to this subject. So pre-COVID, so BC, I guess in Giles, Chris' words, I was sort of a plain old-fashioned macroeconomist working on fiscal and monetary policy. And then sort of when COVID hit, like many other economists, we sort of dropped kind of what we were working on and then started thinking about the policy trade-offs having to do with COVID, and in particular started to integrate sort of these models from epidemiology with macro models to, like Flavio had been doing for many, many years before us, to think about sort of policy trade-offs having to do with the pandemic. I wanted to, in terms of my observations, just say some very broad things, also picking up on some of the things that Chris said. So essentially, I think there's sort of things people sometimes get wrong that we should sort of take off the table pretty quickly. And in particular, there's sort of one simplistic view that sometimes people have that sort of we should sort of dispose of, I guess, which is that the idea that if there hadn't been lockdowns, the damage to the economy would have been really small or non-existent. So there would have been only a very mild recession or no recession at all. I would call that sort of the cardinal sin of pandemic economics, if you can call it that. It's obviously, it's a hard question because it's a question about counterfactuals. So what would have happened if we hadn't done the policy we did do? But I think there's still pretty clear evidence from the evidence that we do have that if we hadn't done lockdowns, there would have been severe damage to the economy. A nice piece of evidence to point to in this regard is a comparison of Denmark versus Sweden. So in Denmark, they did a pretty hard lockdown. In Sweden, they didn't. There's a nice paper that looks at sort of consumer spending in the two countries, and you see consumer spending fall in Sweden by almost as much as in Denmark. So there's basically a large recession in Sweden, even though there was a much softer lockdown.
So that means it's the health crisis that's causing the economic pain, not the policy.
Well, I was going to come back to that. So to a large extent.
Yeah.
To a large extent, exactly. It's the health crisis that's causing the economic crisis, and the idea is it's sort of a fear factor story, right, where if there's a raging epidemic, people stop going to restaurants, stop traveling, and so on. The economist's word for this is called voluntary social distancing. So you kind of voluntarily cut back your social activity. And that by itself leads to a large recession. Then on the other hand, I do think there's on the other extreme, there's also a simplistic view, which I kind of also want to take off the table a little bit, which is if you do a blunt lockdown of the type we've seen in the UK, where you, in spring 2020 and the winter, where you really close down everything, so you close down schools in particular, these kind of things. Sometimes there's people who say there's no trade-off involved in this at all. I think that's also kind of wrong. So, even in the Denmark versus Sweden example, you do see more of a drop in economic activity in Denmark than in Sweden. Not by much, so there isn't much of a trade-off, I guess, through the lens of that data, but you do see it falling more. And also any sort of theories of economic and epidemiological interactions I've ever seen, you do get some sort of a trade-off between life and livelihoods if your only policy tool is these sort of very blunt lockdowns. It may be a small one, but you do get some. And part of the reason is really adverse distributional effects of lockdowns. So there's some occupations and some groups in the population who are very hard hit by a lockdown. For example, if you're a waiter working in a restaurant or you're in the travel industry, a lockdown just takes away your livelihood. And so to say that there's no trade-off is also kind of, I think, wishful thinking in that sense. I did want to follow up on one thing that Paula said in terms of this cost-benefit analysis in terms of vaccines. So I would agree with Chris there that once you take into account the macroeconomic implications and in particular the effects on livelihoods, so we've done some calculations at some point in the type of models we've worked in. It's very hard to come up with a scenario where basically, any price you pay for the vaccine isn't justified. I mean, I'm exaggerating a bit, but it's very hard to argue that you overpaid for the vaccines in the type of way of thinking, just because the whole pandemic and therefore the economic crisis wouldn't end until you vaccinate people, I guess. So I do think that's important. Then let me conclude with one more thought, if that's okay. And you said sort of an idea. So and in particular, the idea I want to conclude with is the need for more sort of joined up thinking between health and economic policy. And I like very much this idea. There's an economist named Tony Yates. I think I've heard him mention this for the first time. He said we should have a center for epidemiology and economics, he called it, where we combine sort of the expertise of epidemiologists, public health research and so on, and economists, and people really start thinking harder about coordinating a bit more. And if we did that, I think we could do much better policy. In particular, we'd also avoid, I think, what I would say is some bad policies we've seen. For example, there was a well-known policy we saw last summer named Eat Out to Help Out, where the Treasury went and subsidized people going to restaurants, right? Which I don't know if you think about it, is kind of an insane thing to do if on the one hand you're trying to lower infections and on the other hand you're subsidizing people doing this risky activity. And so these kind of blunders in policy, I think, could be easily avoided by just people coordinating a bit better in government and talking to each other.
It was fantastically popular, though, wasn't it?
Yeah.
Do you think? One of the phrases that we hear from politicians at the moment, just apropos lockdowns, is we now have to learn to live with it. Is that true?
With lockdowns, you mean?
No, with the virus.
If only.
With the virus.
I do think that's true, just because of the sort of waning immunity we've seen. So Flavio has written about this. If there were permanent immunity to COVID of the type we see for other viruses, then I guess there's some hope of eliminating the virus in the long run. But with sort of the type of waning immunity you see, the fact that even previously infected or vaccinated people get reinfected, then the disease does become endemic. And so meaning it's...
And endemic means it's there all the
yes,
time.
Exactly, like seasonal flu viruses.
So that's unless there is I don't know the right word, Mel, you might be able to correct me, an entirely immunizing vaccine, isn't there, if we can eradicate it?
Yeah.
Sterilising, yes.
I think this is a very good moment. I was going to bring you in, the floor's yours.
A little twist on that question. So there are two ways of interpreting that question. Learning to live with it is just, acknowledging the fact that we still have infections and therefore dealing with it going forward. I think that's right. Now, there's another interpretation with to live with it, which is basically, since we're never going to get rid of it, we just don't do anything. And I feel that many people have actually used that interpretation. And I think that's wrong. Right. I think just because it's been bad, going forward, we still have to do the best thing possible. And so we just have to deal with the situation as it arises. But if I may give some reflections on...
Absolutely.
Yeah?
The floor's yours.
So I thought, since this is an economics event, and you're probably here mostly because you're interested in economics, I thought I'd take kind of what is my post-mortem on what is the government policy in this space. Maybe it's a bit too early to do post-mortem because we're not quite through. Let's do post-mortem for the people who are no longer with us. So I think I like to think of three main areas in which I think we could have done better as a society, or maybe in particular the government. The first one, I think, has been a lack of foresight, or a lack of rather an ability or a willingness to look ahead when we make policy decisions. So there was an unfortunate interview a few months ago where Rishi Sunak, the Chancellor of the Exchequer, said, well, we can't predict what the epidemic is going to do, and all we can do is really react to that. And the interesting thing is that if he were right, then of course we wouldn't need SAGE, because the whole point of SAGE is to try to figure out what are the likely scenarios. And so if you have this defeatist approach that, we can't do anything to predict what's going to happen, then all the modeling is completely in vain. So clearly we can say something is maybe not perfect, but we can see ahead to some extent. And then that begs the question: if we have these modelers who tell us what are the likely or the possible scenario we could face, we can start thinking about what are the consequences in terms of both livelihoods and in terms of economic outcomes. So there has been a very, very simplistic approach, or rather attempt by the Office of Budget Responsibility to say, infections go up and then they go down for 3 months and so on. Of course, completely naive, but this is the right kind of analysis we should have been doing all along, and Tony's center would have been a perfect venue for that kind of research. Now, the first thing is, I think, a lack of willingness or ability to try to look ahead. The second, important shortcoming is to go back to what you were saying about cost-benefit analysis. Of course, that's not just in terms of individual drugs, but in terms of any policy we might want to implement. And the weird thing is that the government has a very nice manual for how to do this kind of analysis called the Green Book. Now, the Green Book, of course, is full of good information about how do we deal with uncertainty, how do we deal with health outcomes, how do we trade off, economic value against lives and disability and so on. So it's kind of a failure of imagination that we've had all these bits, all these tools, but nobody's thought of, let's get these things together and actually let, these good principles that are in the Green Book, let's use those to guide policy. And the last, I think, big failure, and it all ties together with the other points, is a siloing of scientific advice. So basically, early on, I think the government rightly recognized that this was a health crisis, there were economic dimensions to it, and there was something to do with behavior. And what they did is they said, well, who are our crack team for economics? That's the Treasury. Do they know anything about infectious diseases? No, they don't. Some of them might have been infected with a disease, but that doesn't count, right? On the other hand, you had SAGE, which had SPY M and SPY B. SPY M are the modelers. These are very capable people, but as you said, they're not trained in thinking like economists or thinking in terms of policy. These are, very, very good people, but they are in a tradition, in a scientific tradition that is just not very useful for looking at situations with behavior and so forth. And the third, of course, the third arm of this trinity, as it were, to mix metaphors, is the behavioral scientists, which have been useful for some things, but perhaps not useful in the way we would have liked. So I can't. There's just temptation is too high. There's a paper that says understanding the dynamics of infectious disease transmission demands a holistic approach. Yet today's models largely ignore how epidemics change individual behavior. Now, this was a paper published in Nature in 2007, okay? And not just in 2007, by Neil Ferguson, who is the person who wrote the study of the Imperial College that the early pandemic planning was based upon. So the epidemiologists clearly have identified years ago that this is an important issue, yet they haven't yet come to the point where they have operational models that can help them in this endeavor. And this is where people like Ben and myself and you might be able to contribute going forward.
So I have two questions on that. First of all, the modelling of the epidemic itself has sometimes, made economists' forecasts look not too bad. Is this just because it's so difficult when there's new variants coming along? So last autumn, the modelling was essentially said that things were going to get better, and then they got far worse. And then quite regularly this year, we've had the modelling say things are going to get a lot worse, and they haven't. What's been going wrong in these models?
So there are two things. First of all, we don't always know what the right model is going into an epidemic. We don't know the properties. We don't know how infectious it is, whether people who are asymptomatic can also transmit the disease. And so there is always going to be an element of learning as we go. And looking back, some of the advice, of course, was completely wrong, but it might not have been wrong at the time. For example, we now learn that maybe surface transmission is not such a big deal. Does that mean the advice was wrong? No, but given the information at the time, this was possibly okay. Now, I do think that behavior, the lack of modeling of behavior, is a big deal, and I just think that's an omission. I think for historical reasons, epidemiology has grown out of the natural sciences. and so they're just not used to deal with behavior.
And so what is the insight that you can bring the audience here
Sure.
about behavior and epidemics?
So-
What's the big thing that economics can tell us?
Right. So for example, Ben had one instance of this, which is counterfactuals. So one of the things that the modelers will have is this thing called the reasonable worst case scenario, and the reasonable worst case scenario you would all think by the title that is what we expect to happen if we don't do something. Okay, so these were the kind of these early numbers, about 500,000 deaths if we don't do anything. Now we know that people actually do quite a lot to protect themselves. And that's exactly what is reflected in the Swedish-Denmark data. People actually have an incentive to care for themselves and their loved ones. And so this is just an instance in where, not taking into account that people will change their behavior will actually, get the forecast badly wrong. But there are also lots, there's a litany of such examples. Another very nice example was the mayor of London who decided he was going to close down the London Underground. And the idea was, let's not get people too close to each other. Let's reduce services and just say to people that only people who are essential should be using the underground. Of course, that message didn't quite go through. And so what happened is that a lot of people who just wanted to use the underground anyway, they did it on a reduced service. And so rather than having people more distance between each other, you had people on top of each other, which was clearly this is because of a lack of realizing what incentives of individuals were.
One of the, I think that this is for everyone on the panel, the insights from behavioural modelling right at the start of the crisis was people in Britain, they just won't accept lockdowns, and that's why we shouldn't have it. Is that just because maybe economists don't understand behaviour as well as we like to think we do?
So I don't think economists were the ones who said that.
Well, it was the behavioural insight team, wasn't it?
Yeah, but I don't know. We can quibble about whether those are the economists.
Yeah.
I don't. I certainly don't.
That was a failure of policy. Some of expert advice.
I think what we've really, there is no economist on stage. I don't think there's an economist on independent stage. And I've sat on a Treasury roundtable with some economists, but I don't know what value that was. There has been no economic kind of debate in this. And there could have been a whole stream of them and asking, and maybe they've asked for advice and we just have been a bit shy about and modest saying, no, nobody's asked us. But I'm pretty sure, we've been waiting. Media's got our phone number, but no.
Could I just add who it was who said, John Edmund, who's one of the very senior epidemiologists, he came out and said, we did not look at lockdowns early on because we thought that the policymakers were not going to wear it. So we didn't even propose it as a possible policy. That was the modelers. I'm not blaming people. He might have been right in thinking that they were not going to wear it. But I don't think that this is something you can lay at the door of economists.
Yeah. Ben?
I did want to add just one observation to what Flavio said, which is once you do actually add behavior to the epidemiological models, they do much better quantitatively at predicting the epidemic. So the issue with the just pure epidemiology models is that they kind of predict that the epidemic would move very quickly and also be over kind of pretty quickly in the absence of lockdowns. Instead, we sort of see the epidemic kind of move much more slowly, drags on and on. And one way of getting that in a very easy way is exactly to introduce behavior into these models whereby people sort of protect themselves, and that sort of slows down the dynamics of the virus. And so I don't know, we built this model, for example, of, in this case, the US economy and the epidemiological and economic interactions. And this was never meant to be a model for forecasting things. But we wrote this paper in the summer of 2020, and I just looked back at the predictions for deaths and so on, how it is now, and it's actually, it's kind of off because there's like new variants and so on, but it's not very far off. And the reason I think is the modeling of behavior to a certain extent, and it's certainly better than if you just looked at the plain vanilla epidemiological models without adding anything, any behavior in there.
Mel, I really want to come back to you now. You've heard from 3 economists on the panel. From a practitioner's point of view, how does this sound? Does it feel otherworldly, or does it speak to the actual problems that you face on the ground?
I wish I could have recorded the conversation I had with my colleague last night. He's really interested in systems, and he's just like, it's so frustrating that all these worlds are so separate. Like we have no, like I said, no training in it, and it's absolutely ridiculous that no health economic teams have been involved in any of this. Like that's just stupid, isn't it? Like you can't say we've got the biggest crisis in healthcare and economics in the entire world ever, and the people that are most knowledgeable about it are not involved in policy making and things like that. So I think one thing I was thinking about when Paula was talking about qualies and vaccines and things, from just a pure anecdotal point of view, the people that are using up, so we hate talking like this in healthcare because we're obviously meant to be holistic and lovely and save everyone's lives and all the rest of it, but actually realistically in intensive care we are a finite resource. We use a stupid amount of money. We use a lot of untrialed or unnice approved treatments and medications and strategies, and we just do it because by the time people get to us, it's their last chance of living. And a lot of our decisions are, is what we're doing for this person going to give them a good quality of life afterwards? Are they going to survive their illness to get to a point that they get a quality of life that's acceptable to them? And actually, on a population basis, that's not what we should be doing. We are now, the people that we are keeping alive with COVID, we are keeping them alive because the treatments are actually pretty impressive. People that weren't definitely not surviving in the first and second wave are now surviving, but they are taking 7-8 weeks of ICU and then another 2 or 3 months in hospital to then not become people that contribute to economic well-being of the country and will continue to use up resources. So because it's a crisis and because in healthcare we're like, we have to do everything we possibly can to help everybody, and if we don't do that, we're bad people. We've just thrown everything at it. So I think, and looking at the people that we're looking after, they are the unvaccinated people, and mainly are the people that take up the ICU resources now. So I would agree that actually I don't think that there's particularly a cost that can be put on, because we're now stopping young people who would have been dying coming to intensive care, and they're the ones that can go on and contribute in the future. So I think there probably is a cost, but at the moment what we're seeing is vaccines are invaluable to the contribution of looking after intensive care, looking after people and preventing long-term problems.
And how does it work? Is it sort of at the door of ICU? Is it a first come, first served, or how sick are you? Or do you ever take the view, how much is this going to cost? Is it worth it? Which is the sort of cold economics
So
question.
in the southwest, we've been the least hit, whether that's because, we're a relatively rich, I guess, part of the country. So we've got, when it comes to social behaviours, we've probably got people that are more well informed. We're probably a less socially diverse population. So the behavioural side that's contributed to the pandemic being a problem is probably less pronounced in the southwest than it is other parts of the country. And we have been at maximum capacity, but never to a point that we've had to decide, like we didn't have to go into the Nightingale. We've never had to decide on limiting people being admitted to ICU for absolute acute issues. But by doing that, by filling our intensive care units with sick acute people, we have now cancelled life-saving operations. For example, cancer operations in 40-year-olds who, if it was cancelled 6 weeks ago, had a potential for surviving. If they then have their cancer operation cancelled 3 times in a couple of months, they then end up with metastatic cancer and they die in 2 years' time. and never get back to work, or people who have a heart operation that will make them better and potentially get back to work.
And they still need some time in ICU after the operation.
Yeah, and so even though our resources haven't been pushed to sit there and decide, actually you can't come because we're full and our doors are shut, we've still stopped.
Who does decide? How does this decision actually take place in the hospital? Because Paula, as a health economist, you would say you'd have some views on this.
I guess, so as economist, I'm in the privileged position of informing, I don't make any decisions, informing population-based decisions.
But it has to go down to the ground.
And it has to go down to the ground, and I appreciate you sit there with that one patient in front of you, and you're not even prioritising because there's only one patient in front of you, whereas the prioritisation happens up high. And I guess, and I'm assuming it's the operations manager or something who decides.
Well, so for example, a shift, I'll come in at, yesterday, went into work at 4:00, and they've been working during the day. There's 5 or 6 people out and about on the wards and in ED that we know, the emergency department, that we know might need intensive care, so we keep an eye on them. Some of them get better and they don't need to come, and others we decide when they get to a point. So last night when I arrived at work, we actually had one empty bed, which I haven't had for a really long time, so you kind of think that you're flush with resource. But that one empty bed I then used by 10 o'clock last night, and so this morning I missed it because I came here, but there is a meeting with the surgical services managers, the surgeons who are clearly fuming that they can't do their operations, the intensive care doctors, and the bed managers who are trying to get people moving through the hospital to say, we have now got our full capacity in intensive care. We cannot do any operating today. If we are able to discharge X, Y, and Z people from ICU, then we might be able to do 2 or 3 operations today. Or let's readdress it at 11 o'clock, depending on what the discharges from hospital are like. The issue in the last few weeks is actually discharges from ICU have been blocked both by beds in the hospital and then on to social care and all the things you hear in the media. But also a lot of our patients aren't well enough. We may only have 1 or 2 dischargeable patients a day. So the turnover, mainly because people are sicker. If you needed a heart operation in March last year and you end up having it in August, rather than your 2 or 3 days of intensive care post-operation, you're now potentially in ICU for a week or a week and a half, and you are sicker, you're using up more resources, and your movement through the hospital is much less. So the decision-making about the operations is done at 8 o'clock or 7:30 in the morning, and I think about it at 4 o'clock in the evening. I'm like, well, this person does need ICU. If I bring them to ICU, that's a bed taken away from tomorrow, but there's nothing I can do about that now. That person needs it more than the person in 12 hours' time.
So Paula, this raises a lot of questions about things like resilience, which I want to come to in a second. And I'm going to ask 2 more questions of the panel, and then I'm going to open it up to the floor. So please get your questions ready. Please ask questions. Doesn't matter how. If you think they're stupid, doesn't matter at all. Just we'd love to open up the discussion. But Paula, we are seeing this now. We're seeing the effect of COVID on population-wide other diseases now, aren't we? And we're seeing excess deaths. So that's the concept of more people dying. It's quite easy to count. Unfortunately, it's quite easy to count bodies than normally, and that's been happening for the last 16 weeks, well above the 5-year average in the UK. And it's not COVID. COVID's a bit of it, but it's other things. So you've said a number of times, Paula, that people haven't asked health economists what should be done. What should be done?
We'll have to do something, and I think it's going to be a long-run strategy, which unfortunately is not going to solve your problem tomorrow or even next year, Mel. I think we need to restructure perhaps the way that we deliver healthcare, so we don't have this kind of knock-on consequences for other conditions. And in fact, COVID's created a new condition, which is post-COVID, which is, as I said, is an area I'm working in. The government has funded post-COVID clinics currently for a year. We don't know if that's going to be a continued stream of funding, and if 10% of everybody who gets COVID ends up with post-COVID syndrome, then you've got a whole new condition that you need to manage. How do you manage it? We're looking at that. With the government's putting a lot of money into new diagnostic hubs, so you can go and get your, there's a whole nother panel about Nightingale hospitals and whether we needed them or not. But in a Nightingale hospital, I think in some places you can now go and get diagnosed for cancer, which is great. But then you've got your diagnosis, which you didn't have before, so that's somewhat better, even though you've now got something you didn't know you had. But then you're going to get funneled into the system where you can't go and then have your biopsy and your surgery because you're still trying to deal with, COVID that is completely swamping your hospital. And so there's got to be, and it might be that some sort of community-based healthcare, allowing GPs to do virtual appointments if they think that works. We don't need to see everybody face to face, but some restructuring, I think, of the healthcare system with money attached to it, with new, and I know we're talking to hopefully a bunch of economists in the making, if not already economists, but new medical graduates in there, because obviously there's a whole workforce issue, that the workforce has been depleted, that is then there to go back on, to use your army analogy, the front lines again, into a new health system.
So we're talking about medical students and how we get trained. So we're trained like you were in the 1920s, when the only option was really to cut out an appendix or crush up some, wheatgrass or something and chuck it at people. Like, you were the only person that could do the thing you were trained to do, and therefore you're allowed to do whatever you wanted. And there was nothing that played into that. It was just one or two treatments and now exactly the medical students of today need to know that they need to be trained to work in a system that is affected by economics and managerial stuff and human behaviours and all the rest of it in order to deliver effective care. But the current problem is that the NHS, I think, you can go out to GPs to do stuff which they're on their knees, the doctors and nurses are on their knees. There is no resilience, there's no flex at all left in the system. And I think I totally agree. It needs complete remodelling, but you almost just need to stop and start again, which you can't do.
You literally can't. Just before we open up to the floor, just wanted to ask the two economists, Ben and Flavio, that what you used the resilience word, and do we need more? Do we need to run economies in a more resilient way and less optimal way in future? Has COVID given us that lesson, Ben?
It's an interesting question.
Which means there's more redundancy, more inefficiency, but we can deal with bad things that happen when they happen.
Right. I have to be honest, I've not thought about this question very much. My gut reaction would be not necessarily. It's more like we need to have good contingency plans. And we know that epidemics can happen. And I mean, we've now learned the hard way, and I guess the next time it comes around, I guess we better have some better plans rather than sort of running around in this completely blind way. Like I think we saw a lot of policy in the early stages of the pandemic. So, for example, having sort of better plans of how do you have a good lockdown strategy from the beginning? How can you fast track vaccine development and so on? I think they're all like margins we could have way improved. And I think, I wouldn't then for the probability of, an epidemic happening once every 20 or 30 years, I wouldn't run and the economy sort of less efficiently, for the 20 years in between, just to hedge against that. That would be my gut reaction.
Flavio?
So I agree. I mean, there are some things that happen fairly rarely. You don't want to completely change your life for those events necessarily. But I kind of object to the dichotomy between efficient and having buffers. Sometimes the right thing is to have buffers because there's uncertainty. But I think there are some lessons to be learned about how to be agile in policymaking. And I also think businesses on their own accord will probably have learned that having just-in-time production and having very specific supply chains might have been a mistake, and so they will probably have learned their lessons about sourcing things locally rather than globally in all instances and so on. So I think we will see some changes going forward, even if we don't do anything. Yeah.
Great. Now I think it's time. We've got roving mics. Please ask a question rather than make a statement. I can see some hands up. I'll take the gentleman in the third row just here. Just wait for a mic so everyone can hear. And please do ask a question, and that means a sentence which ends in a question mark. Just here, coming forward. Bit further. That's it. Lovely. Thank you.
Hi, I have two, if that's okay.
That's fine.
My first one, it seems as if there's a problem with communication. It's a communication barrier. During the height of COVID, how often did think tanks and forums like this happen, where policymakers came together with economists, and came together with health experts? It seems as if maybe during the height, people sort of retreated to their own fields. I wonder if that going forward is what sort of needs to change. And the other is, a lot of academics said that a post-mortem of the global financial crisis was, again, behaviorals. People were looking at behaviorals, people were looking at psychology, and that apparently seems to have happened again now. So how do we need to, going forward, change? Do we need to just encourage more of a focus at looking at behavioral economics and psychology? And
Flavio, I think.
So I can tell you, just between you and me, that people on SPY-M, that is the modelers, they've asked at some point whether they could talk to the Treasury people, and were told in no uncertain terms that was not their job to talk to them. They should get back to their modeling, and that the Treasury were going to take care of that side of things. Now, Ben and I have also engaged with the Treasury people, and they've listened politely, but I don't think I've seen much in terms of changing of minds. So there have been some contacts, but I don't think that there's much to show for it right now. And then I think that has been one of the missed opportunities. Now, just to be correct on the financial crisis, the behavior I'm talking about is not the behaviorals you're talking about in terms of bounded rationality and biases and so on. This is just any kind of behavioral modeling, rational or irrational. Epidemiology lacks it. So the kind of stuff you're talking about now is kind of second order sophistication in some sense. We don't even have the basic behaviorals sorted within epidemiology.
Ben?
Can I just add something quickly? So I think this sort of communication barriers that you refer to, I think they definitely were there, but I think they were particularly bad within government and sort of outside of government among academics. It actually wasn't so bad. I was at plenty of conferences where there was sort of both epidemiologists and economists, or public health people on panels and talking to each other. There's plenty of examples I can point to of papers being written by teams of epidemiologists and economists. Flavio has a joint paper with an epidemiologist at Harvard. And for example, to come up with better testing strategies, or how to allocate vaccines, or these kind of things. And so I think those things were being discussed. It's just somehow they didn't make their way into policy, and partly that the reason is the siloing mentality within government that Flavio is referring to.
I don't think the 5 p.m. press conference, I can't remember, it was at 5 p.m. I think. I don't think we ever saw the Minister of Finance. Did we ever see the Minister of Finance?
You did, occasionally.
Boris had COVID, he might have.
Yeah, okay, might have stepped in then. But it was definitely, it was a health press briefing, not an economic press briefing.
And I think the Treasury sometimes, I mean, this is maybe over-interpreting a bit, but I had the feeling they sometimes saw themselves as sort of the lobby of business, and their sort of job was to argue against the scientific advisors that are trying to lock down their business, and rather than sort of coordinating and coming up with a plan where the key insight is really what's good for health is also good for economy. So you should be pulling at the same string.
Far be it from me to defend the government or civil servants or public officials, because I normally do the opposite. But I do know that both the Office for Budget Responsibility, the Bank of England, and the Treasury at the official level have certainly had quite a lot of discussions with Chris Whitty and Patrick Vallance, and have been trying to get, as best they can, the pandemic insights into their modelling. So I mean, I think it might not be very public, but when you talk privately to people, for example, at the Bank of England, they get briefed every meeting now by the chief medical officer, as well as all the economists as well. So it isn't necessarily quite as bleak as it might sound.
So I think just from a communication from a healthcare onwards, I think those conversations, between these four walls and just with anecdotal things that I've heard from people that have been on these committees, there is a discussion happening. There is then potentially this disconnect that goes from the final policy makers and deliverers. Again, not particularly commenting on politics, but it's. But I think going forward, there is a massive need, as I've said repeatedly, from a healthcare point of view, there has to be some better communication in how we run our systems. And that would maybe build in some resilience and some for future problems without having to run the healthcare at 50% occupancy for the next 30 years.
Other questions? Just see who's got their hands up. Take the man right at the back. It's okay. There's no queue. We've got time as well, so there's time for everyone to ask questions.
I'm going to be a bit harsh, just to wake everyone up and liven the place up a bit. But we're all familiar with the term blah 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 just recently, and drip drip drip. And what I'm hearing is, you've got your person in the middle who's from the health service. The health system, it's fucked. It's totally fucked. You go to a doctor in Bristol, it's fucked, right? It's on its knees. Your colleague, described it. And you guys are sitting there going, oh, we'll do a bit of this, and maybe we'll have a little bit more efficiency in the vaccine process. And I'm just hearing, the question is, where is your fucking vision? Where are you actually taking the hold of the situation that we've been through and coming up with something new and radical and talking about how we solve these problems in a way that is kind of actually effective, rather than just this kind of tinkering at the edges just to finalise that question, you people from academia and a lot of you universities, you're actually quite compromised in where you get your funding. And to what extent are you kind of unable to say what you really think, because actually if you do, you're going to mess up your funding streams and you're going to offend the people that are paying your bills and your mortgages. And your
okay, thank you very much. That's the Greta Thunberg
I think that's a macro question, isn't it?
Well, I think it's actually a perfectly reasonable question. Are we just, fiddling at while Rome burns? Where is the big vision? Ben, I'm going to unfairly ask you to answer that.
No, I agree. It's a perfectly reasonable question. I mean, I would say part of the issue with the health system, and I'm speaking here as a macroeconomist, so this is not my area of expertise. But part of the issue is that there were, short capacities and issues way before the COVID pandemic. So this is nothing to do with the COVID pandemic. And I guess I turn that over to my two colleagues over there. What exactly needs to be done? I guess to a certain extent, just more money, and then allocating that money in a better way. I mean, the other thing I would say is then coming specifically to epidemics. I do think, I mean, maybe that's not quite what qualifies as radical in your eyes, but having something like a new institution like this Center for Epidemiology and Economics, I think potentially would be a big step forward and help resolve a lot of these issues. And then finally, just about the funding point, I mean, I've personally, at least, never felt constrained in any way in what I can say. And I mean, I've definitely been quite critical of government and in this panel and in other occasions of sort of big businesses and these kind of things. So I've never had that issue, but and I think probably most of my colleagues here would agree. But
Paula, do.
And it's not that we're short of ideas, but ironically we're short of funding. And so if you look back and you look at what has been funded there was a large amount of money that was put out for pandemic research. There are actually very few economic studies that were funded. but it's clearly an economics question. So in fact, we probably do have the ideas. We do need to research the ideas and work out if they work before they then get implemented. So I don't think we're short of ideas. Unfortunately, at least 3 proposals that I put in that were kind of economics based about how can we manage waiting lists in another part of the healthcare system, understanding how to prioritize vaccine allocations, and globally, those sort of things are just not being funded because they rightly put a lot of money into vaccine development, which we can see has been successful.
Flavio, could I just ask you a question that you can give your, which is related to, is it really true that there haven't been radical thinking from economics in the pandemic? We've had lockdowns, we've had a furlough scheme was entirely new, £70 billion spent, we had £250 billion of public money. We've had a huge amount of quantitative easing to finance that. We've essentially monetized public debt in this crisis, and we've come out of it 0.6% below where we were. It's been quite radical, I think.
I'm afraid I can't really agree to this assessment. First of all, I think the criticism is completely misplaced. We don't make decisions up here. We are not decision makers. We are academics who give, who share our knowledge and our research, and so we are not decision makers. If you're unhappy with the policy, don't vote for Boris next time. That would be my advice. Now, in terms of our funding, you might think we have cushy jobs, but let me just remind you, as an economist, I've could have earned 10 times or 20 times more by being in a bank rather than doing what I am doing. So I kind of resent that my funding should be brought into this. My research is publicly available for anybody who wants to read it. It's transparent, it's there, available, and so I invite you to consult my website if you want to know more, and then you can decide for yourself whether it's biased by by me being paid a wage. Now, in terms of activity, no, I don't think we can say that there hasn't been enough activity. Probably it's just been the right activity. So in case no people didn't realize, what I actually suggested, even though I didn't raise my voice, was a complete rethink of how we do economics and pandemic management policy. I don't think it gets much more radical than that.
Good. Other questions? There's a gentleman in the second row here. And we've got a reasonably diverse audience, but I've only seen men so far put up their hands, so I'm challenged. I'm now seeing a woman, and two
one
more.
Of the 25% that I've counted. Well done.
So, though you'll get next, but go for it.
Talking about management of the pandemic, isn't it true that the biggest single failure was a lack of a national stockpile of PPE in advance of the pandemic? And isn't this a managerial failure rather than an economic failure? I mean, I happen to have a responsibility separately as chair of a group of care homes in Bristol, and at the beginning we couldn't get the PPE. Once we did, we drove down infections to 0 for 5 months prior to vaccination. So isn't this a managerial rather than an economic failure? But if I can ask an economics question, when you look at the allocation of GDP to health, say in the UK, Germany and USA, something like 8-9% GDP spent on health in the UK, something like 12% in Germany, something like 17% in the USA. My question would be, how much of that differential do you think is maybe sheer waste and inefficiency, perhaps in the USA, and how much of it is the deliverable of greater resilience that Chris was talking about, i.e. perhaps in Germany, who've got far more A&E beds per head of population than the UK. So this is an economic question, but doesn't it also take us into political economic space?
Well, this is a funding question. No, I can imagine your answer would be yes. We need more money and more resilience.
We need more money, but we need to do it better than we're doing it. So it needs to be done in discussion with economists and people that have some idea of managing systems, which, as clinicians, we don't. And so, I think. Yeah, I mean, more money is excellent. The problem is that money doesn't automatically, like, there's not, like I saw, we're way down on our numbers of doctors per population, we're way down on numbers of nurses population. I left medical school in 2006. I started in 2001, so like it's taken me 20 years to be able to play my role in the COVID pandemic that I've been able to do. That's one person. I've cost the country a lot of money in order to do that, but that's 20 years in the making. Like that just by giving money, that doesn't make it better. So there's definitely need for more funding, but there needs to be a better, more intelligent way of using it to make that effective, I think.
We're already putting up taxes in April by 2.5 percentage points of earnings. Paula, do we need to do a lot more in this country?
I think if we're going to put more money into health, we need to work out where we're going to put less money. And so do we spend less on education? Do we spend less on defence? Do we spend less in transport? So it's that kind of working out, you've got your public purse, and where are you going to distribute it? And I think, I'm trying to think of some kind of more recent papers, the public is generally quite willing, not partly to pay more tax if it goes into health, but I think we need to think about whether we put more money into health and actually that means less money into those other areas, which is a difficult question. One of the reasons that it's very hard to compare countries in terms of the amount they spend according to their GDP, is particularly because in the UK we might get a better bargain because we have organisations like NICE driving the price down. So it's not just about spending, it's also about what you're spending and what you're buying, I guess, in some sense. So we know that in the US they're buying a lot of luxury items. You know, everybody's got 2 COVID jabs and a facelift. But comparing us, I guess, more to a more similar economy in terms of the healthcare system, it might be actually that we're being more efficient with our pricing, although clearly there are some inefficiencies still in the system in terms of the wastage.
Could I just warn against spending too much or focusing too much on costs? Because we what we really want is value for money, and I think there have been many examples in this crisis of just incompetence in the procurement process. So PPE where we overspent on, which is not fit for purpose, that is not used for anything. Vaccines that we paid for that are not given to anyone. You know, airplanes being flown down to Turkey to pick up PPE, stuff like that. Very, very fat fees given to middlemen who didn't really, contribute much.
Except to the Tory party.
Well, let's put that to one side. I mean, I think we shouldn't just focus on the monetary value, but also what we actually got for that money. And I think there's been tactical mistakes.
I think just
throughout. Yeah.
Also pre-pandemic, it was very clear that the NHS is not in a sustainable position long term, and so there has to be some sort of thought about how we go forward with funding. And having worked in New Zealand, there's a relative give and take from a private and public perspective. So people are more willing to, you pay to go and see your GP. It's a really nominal fee. But my old housemate was happy to pay 90 quid for a sports massage, but kicked off when she couldn't get an NHS dentist appointment. So I think there has to be some sort of discussion about responsibility. There has to be government funding, but we do have to think about going forward how we provide healthcare to the entire population, and it might end up needing to be some sort of staggered system. That's obviously going to be completely delayed because of the pandemic has added a disaster into that.
And we don't really have time to talk about the other thing. I mean, we've got an ageing population, so this question is not going to go away in future conferences here at the Festival of Ideas. It will be coming back and back again. There was a woman at the back who had a question.
So obviously one of your main concerns was that the majority of people that were in ICU units for intensive care for COVID were non-vaccinated. And you're talking a lot about how behavioural economics needs to be implemented more into epidemiology. How much discussion has there been about how to encourage people to get vaccinated, and how short-lived will that be? Is the treatment a long-term effect? How much can people actually do to encourage vaccination? And I guess I've seen a lot of correlation between trust in government and inequality and unemployment. Do you think then that encouraging people to get vaccines isn't really something that's a short-term solution?
Yeah, it's so. So I think short term, the vaccine is clearly making a difference, but there are so many at play. So for example, in kind of August, September time, we had a massive Eastern European population. That we had just every admission was an unvaccinated person from Eastern European, recently come to the UK background. And there'd been a load of work for the Black and Asian communities and there was loads of all the Muslim doctors at work were doing a lot on Twitter, and there were a lot in their communities. After the second wave, where the people that were dying were sadly the Black and Asian populations. But then there's a sort of load of Eastern European people coming through, and you're like, well, actually, have we been focusing? We've focused on one population, we haven't focused on the other population. So I think definitely there has the public health messaging has to be better. We have to find out how we can communicate best, but that's in every aspect of life, isn't it? We've got so much to learn about how we communicate with the entire population. It's not the only fix at all, but it's definitely something. And I think now, talking about it becoming endemic, this is going to be a problem. Like the flu vaccine is offered to everybody in healthcare or at-risk people. This is going to be something that's a year-on-year problem, and the anti-vaccination side of it is going to. I mean, maybe when everyone's a bit happier, that will settle down. Don't know. I don't know if that's. It's a symptom of how sad the world is at the moment as well. Maybe.
Now, what do people say when they're on your ward if they've not been vaccinated? Do they feel regret, or do they maintain a position that they were right not to have been vaccinated?
So, interestingly, sadly, so if you have COVID, so at the moment you're allowed to have one visitor a day. For an hour a day. So family members can come into the hospital and sit at the bedside of the person of their loved ones. If the patient has COVID, we can't allow that. But because of the change of government guidelines, if you're double vaccinated, you can become in contact with a COVID positive person and then just PCR test or lateral flow and so when people have come to the end of their life, we have invited their families in. We can put PPE on them, but they're not officially tested, so that doesn't count. That still counts as a COVID contact. And we've had patients that are in hospital for 5 weeks who die of their COVID, and their families have still not gone and got vaccinated. So even though we have a conversation, even though they're seeing their loved ones dying of the disease, it hasn't triggered them to go and have a vaccine, which to me is really sad, but it's also I can't quite get my head around that, but that's something that we need to work out why that's not.
Do anyone else on the panel have any ideas? Do we know anything about what is the most effective messaging to work, Paula?
I guess economic incentives is a good place to start. So New Zealand is trying, it literally changed today. They've just changed their target to a milestone, but trying to get to 90% of everybody being double vaccinated. And they were using incentives in some places.
Like cheeseburgers, didn't they?
Yeah. So and it was kind of more local incentives, but in other countries they've used a kind of lottery system, or they've actually literally paid you. And I don't think, this is, we're economists, rational man and woman, so we should be, thinking in that way. I guess if that's not going to help get you over there, then there's something else which has to, I think, come back to kind of education, understanding what it is why they don't want to have it. And we've seen people lose their jobs in care homes because they've chosen not to be vaccinated. And if that's not an economic incentive enough, that you now no longer have any income, I don't know what it is. So there is something, and I don't know if it's about mistrust of science or mistrust of government or just proper anarchy, which doesn't sound like someone who works in a care home, right? So there is something that we still don't understand about people.
This is behaviour, right, isn't it? So do we know enough about the way people behave when they have strong views? So we've got Austria, who's now got a lockdown only for the unvaccinated. We have Italy and France, who have both very strict rules for what you can and can't do if you don't have in France, your pass sanitaire or your equivalent in Italy. And they have worked in some sense in driving up vaccination rates. I mean, does anyone Flavio, do we do we know what?
I mean, we know some things that do work to some extent. Financial incentives seem to have worked with other infectious diseases, and there's no reason in principle why it shouldn't work with this one. Then non-monetary incentives would certainly also be a big candidate. So, for example, in Australia, you can't send your child, I think, to a public school unless your child is vaccinated. That's a pretty muscular policy if you don't want to exclude your children from education. So there are many tools in the toolbox, but the question is whether there's political will to actually go that way. Because unvaccinated people are also voters, of course. Now, there's another thing, which is that just think about it in terms of economics. The more people are vaccinated, the less do the unvaccinated really need the pressure. So, in some sense, it's not irrational for somebody to decide not to get vaccinated if you see everyone around you are vaccinated. There's just much less of an urgency for you. So this is entirely predictable. So if you have a population where there are some people that are more likely or more susceptible, you would expect those people to seek to get vaccinated earlier, and this is exactly what we're seeing. Younger people are more reluctant because they have less of a private benefit of vaccination, and so this is not entirely surprising.
Mm-hmm.
So I think the two things that I'd say about those points is that the first thing is that I think economic and financial incentives are good for the acute problem now. That's not going to be a reliable process for the endemic yearly vaccinations that are going to need to continue, which is likely to have to happen. And so we have to, even just on a general healthcare point of view, we have to do better at understanding why. And it's not just in vaccines, it's attending GPs, it's taking medications, it's loads of things that we are bad at engaging certain populations in what we deem Western healthcare standards. So that's the fact we have to do better at that. The second thing is that I've completely forgotten. My tired brain's forgotten. What would you just said something interesting, Flavio?
Sending your kids to school.
Sending your kids to school. Oh yeah, is that this vaccine is different and this disease is different to other diseases we vaccinate against. So, in other diseases, you get this. If you vaccinate enough people against mumps or whatever it is, the chances of your child contracting it is much less. So the anti-vaccinated populations are safer, but this doesn't happen with COVID. Like the Delta strain, we can still pass it on if we're vaccinated. It doesn't actually. So the younger people are reluctant to get vaccinated because their private risk is less. But we're seeing 35-year-olds die of COVID in hospital who have no other comorbidities, and you guys mostly are younger than 35. But it is something that's killing young people, and it is something that you don't have, and the behaviour that younger people have, puts them at increased risk. So the mumps and other vaccinating diseases this doesn't model that. It doesn't reflect those models as well.
Do we know, is anyone on the panel, do we know generally when we're trying to persuade people to do something they otherwise wouldn't necessarily do, do carrots or sticks work better? What does behavioural economics tell us about these things? Flavio, I'm looking at you.
So I'm not a behavioral economist, so I can't speak for that discipline. In general, we do a combination of both, right? We do when you pay a parking ticket, they say, it's £50, but if you pay early, it's £30. And so, there's a both of stick and a bit of stick and carrot. But I think there's another thing. Another way we could actually help people, see the light and get vaccinated is, civil society, and by that I mean social norms. That it's okay for people to insist to be in an environment with lower risk. So people always, they focus on individual rights not to get vaccinated, and indeed they have a right not to get vaccinated. But the rest of us also have a right not to be exposed to unnecessary risk. That's also a private right. So I think social norms is important. And second, I think businesses can help a lot. So, for example, some airlines are now requiring vaccination in order to fly. I think Qantas is one of those, or some such airline. And I think we'll see more and more of that. If as a business you want to cater to the vaccinated people, you might be forced to actually exclude the unvaccinated people.
I mean, we're going to get into some questions like, should it be no jab, no job, which it is in the care sector and will soon be in the health sector, but it might be in the private sector.
It is
too.
in many universities in other countries.
Yeah. There's a question, woman in this third row on the end here.
Hi, thank you. It was spoken about earlier in the discussion that there was too much support maybe during the pandemic with, I don't know, furlough and all the other support mechanisms. I think there's billions ploughed into the economy. And that's taken its toll on inflation. I think the ONS have predicted something like 4% next year. So my question would be, do you think this will resolve itself naturally? Is it just an effect of coming out of the lockdown, or does there need to be some sort of fiscal retrenchment or fiscal retrenchment?
So are we going to get a hangover? Is it going to be okay? Ben, I'm going to give that to you.
Yeah, it's a great question. I mean, let me say one thing first, which is, I mean, even if we are going to get a hangover and have inflation, I mean, it's not clear that the fiscal support was too much. I would say that's kind of important. So in particular, I do think most theories I've ever seen that we use to evaluate these sort of policy trade-offs, you find an extremely important role for fiscal support or sort of social insurance of the type we've seen. So meaning that the furlough scheme or say the CARES Act in the United States is good policy through the lens of any economic model I've ever seen. And the simple reason is just that if you didn't do these things, there would be people who are just extremely hard hit, and then the people who are extremely hard hit, so people who work again in occupations like waiters, are also the ones who are most vulnerable. So we've at some point looked at data on people's liquid wealth holdings by occupation, and the average waiter, this was for the United States, has a liquid wealth buffer of something like $800. So you can see that if you don't go, if you go without an income for like 3 months and you have $800 in the bank, you're gonna have a problem. So you're just not gonna be able to put food on the table anymore. So this policy there is just sort of alleviating hardship, and you don't have to be. This comes out of very conventional mainstream macro models. You don't have to be a believer in like heterodox theories like modern monetary theory or anything like this. Like any sensible theory I've ever seen will tell you that you want to do sort of these hardship alleviating policies of this type. You're going to then have a large increase in debt in the long run, and arguably inflation, depending on exactly how you how you think about that. But it's still sort of good policy in the sense of improving welfare. So now there's a separate question, which is, are we going to have a hangover? And I mean, I think it's a very hard question to answer, given what we know. For sure, there's going to be elevated government debt for a long time. So then there's a question of how you have to raise taxes at some point in the future, or it's already happening. And so I guess you could imagine that has negative consequences. And there's the inflation question, which is sort of a little bit related. I don't know. It's very hard to predict. There's some people who say this is all just sort of energy prices and sort of specific prices that sort of are transitorily high and then are going to come down again. And some people say we've sort of lost the inflation anchor. People have changed their expectations. And I honestly just don't know which one it is, if I'm totally honest.
Flavio.
So can I just follow up on that? So this is the perfect econ answer. So let me just give you an econ epi twist to it, which is arguably we should have spent even more than we did spend. And one of the reasons is that all these economic interventions actually have disease control consequences. Yeah. So for example, if you think of statutory sick pay, the UK has one of the lowest packages or least generous packages in Europe. And that translates into people's willingness to actually self-isolate when they become infected. So we have now survey evidence suggesting that people who have less generous statutory sick pay are more likely to go back to work, even if they know they might have symptoms. So I know a case can be made that if we had a more generous system in terms of sick pay and maybe also support for self-isolation than we do now, say, for example, like they do in Germany and other countries, we might actually have come out of the crisis earlier, which in itself would also have been beneficial to the economy.
Okay, we've got time for one last question. Just the gentleman in the back there. There's a hand up.
Great, thank you. Are there, we've talked about a range of different things that could have sort of been improved on in terms of health and economics. Are there any examples of where the coordination, like different aspects of the pandemic, the furlough, the vaccine, where the coordination went well and we could sort of learn lessons from that and sort of feed them into other parts of it? It would be good to get your insight on things that went.
It's a great question to end on. What I think everyone on the panel have views on this, so we'll go. Flavio, you can start. And then we'll go down along the panel.
I'm afraid I can't answer that very clearly because I haven't seen almost any coordination. So to find examples where it's gone well is a hard ask. But if I had to point to one thing that has worked well, it's the vaccine rollout. Now, whether that has been a matter of coordination or whether the Treasury just lucked out that other part of the government did that bit well, that I don't know. But clearly the funding came from somewhere, and so they took a very early bet and put in a lot of money, and so that would be the one success story, I think.
That's the vaccine, Paula?
It's not so much coordination, but I think it's just awareness of inequalities. And so I think now economists are looking a lot more at inequalities. Health is clearly exacerbated inequalities, and it's kind of put them up and elevated it so we actually can address it as a nation. I hope we'll address it as a nation. So I think that's one thing the pandemic has done, which is not something nice, but I think it's something that we perhaps need to be talking about.
That's a better world in the future we might have, because we're thinking about real problems. Mel?
So I can't really comment on the economics, but from a systems-based approach in the NHS, we have combined with the scientific community and achieved vaccines and drugs that are working, and we have learnt to treat a disease that we had no idea how to treat 20 months ago, and that's by just being pragmatic, and things like guideline ratification has happened as opposed to it taking like 4 years once you've written a guideline. So I think the communication I've said for the last hour that is bad, we have actually improved that because there has to be a need, and we just need to learn that we can do that, and we should get on with things rather than faff around.
So we've learned that being fast works.
Yeah, there is a degree of pragmatism
and I think having data as well.
Yeah,
actually, we're a much more data-rich nation, post-pandemic. If we're post-pandemic.
And Ben.
I mean, I've kind of already said it. I would say policies like the furlough scheme, so social insurance, fiscal support policies, are actually a good example of where we did something well, and importantly, quickly. So virtually every advanced country, developed country I can think of, had some sort of policy like this, or very often very different ones. Some countries had these furlough schemes, some people just gave checks to people like the US, but in all countries there was this idea that if we do a lockdown, then very quickly at the same time we need to also help people out. And I think that there actually governments moved sort of impressively quickly in most cases, and that actually worked relatively well.
Yeah, just to amplify that, if you think back to the global financial crisis, we had a six months debate from the moment Lehman went down to try and get the world to agree that maybe a 2% fiscal stimulus, 2% of national income fiscal, was a target that country should do. It was incredibly controversial and took 6 months for it roughly to be agreed. I think in advanced economies it was 11% in the COVID period on average, and it happened in 2 or 3 days. I mean, things did happen quite differently this time around. Certainly from observing it, it was remarkable how quickly the policy moved. I think that's the end of this really fascinating session, showing just how important the subject is and how much more work needs to be done to make sure that health and economics don't sit in silos, but actually come together and inform each other. I'd like to thank the panel, Mel, Paula, Ben and Flavio, and thank you for being a great audience. I think there's refreshments out the back, but can we give everyone a big hand? Thank you very much.